followed by your agenda or your presentation will be there. And at the end of the presentation, sir, we'll take some questions and some questions from the this panel discussion also in the chat box from the delegates. And then, sir, any take-home message all the faculties they want to give to our students, and how to tackle this learning curve in ultrasound and 2D. So basically, the motto is that, because not every intensivist is expertise in this. So the aim is to train as many intensivists as possible to have a better outcome of the patients in the ICU. So with this background, sir, we'll starting in 2 to 3 minutes, sir. Already 30 people have joined us. So let's wait for 2 to 3 minutes, then we'll be starting, sir.
We still have
I
2
think
minutes.
Dr. Rishi Kumar has also joined. Welcome, Dr. Rishi Kumar. So Dr. Rishi Kumar is a dear friend of mine. We were together at Hinduja Hospital and Tata Memorial Hospital. And he is also using ultrasound day in, day out for his patients in the ICU. And would like to hear from Rishi. Welcome, Rishi.
Hi, good evening, Dr. Rishi Kumar.
Hi, Rishi.
Hi.
Hi, thanks, Achilles. Thank you.
Hi, Dr. Rishi.
Hi, Gunnar. How are you?
Fine. Yeah.
Hi, Dr. Kedar. Hi, Rishi. How are you?
And with us, our other faculty or other panelist, Dr. Aditi, she has also joined. So Aditi is working with us as a consultant intensivist, Apollo Hospital. So Aditi, you are there?
Yes. Hi. Thank you for inviting me.
Thanks.
Welcome, Aditi. Welcome.
Thank you.
And the other faculty, Dr. Anand Joshi, he's in Australia. Probably it's too late for him, actually. It's around 12 o'clock over there. But he said that he will be able to join intermittently. So apologies from his side. So I think nevertheless, we will still be able to go ahead good. And with this, I think we are 7 o'clock at the moment now. So can we initiate the program?
Just a minute, just in 1 minute we'll be starting.
Kedar sir, can I request you to start sharing your screen at least?
Yes, sir.
I will do that, yeah. So, can you see my screen?
Wow, yes, we can see the screens.
And am I audible?
Yes, sir.
Very much.
So you want me to start?
Yes, sir.
Okay.
So I'll just give a brief introduction. I'm Dr. Gunadhar Fadi. I'm the coordinator, consultant in charge, Apollo Hospital, Navi Mumbai. So the today's program will be the demystifying lung ultrasound in different respiratory conditions. And today's interactive and interesting sessions will be presented by Dr. Kedar Koraskar, sir. So I no need for any introduction. So the Kedar sir is well known in the field of ultrasonography, particularly in the critical care ultrasound. And I think he is one of the eminent prolific speaker, and he's also has done a lot of this bedside ultrasound examination for different critical care patients. And today he is going to enlighten us about the lung ultrasound, the critical care perspective. He is working as a consultant in charge, Oakard Hospital, Mumbai. And with us, my co-colleague, Dr. Achilles. Dr. Achilles is also working in Apollo Hospital as a consultant intensivist. And with us, there are two other eminent panelists, three eminent panelists, I can say. Dr. Rishi Kumar. Dr. Rishi Kumar is basically, he's a consultant from the Hinduja Hospital. And he has also a lot of interest in the critical care ultrasound. And with him, Dr. Jayant Selgaonkar sir is basically working in Jupiter Hospital, Pune as an in-charge consultant. And he's one of the leading pioneer, and also he's one of the director in the WIN Focus program. And his field of interest is critical care ultrasound and 2D echo. So welcome, sir. Welcome to this panel.
Thank you.
Of learning. And welcome, Dr. Rishi.
Thank you.
Thank you. And with us, my co-colleague, Dr. Aditi Jain. So Dr. Aditi Jain is trained from this Canada, and particularly in the field of ultrasound and 2D echo. And she has definitely a particular keen interest in doing a lot of ultrasound for critical care patients, and particularly she does this work in our ICU. So welcome, Dr. Aditi, to this forum.
Thank you.
Yeah. So with this, let's start today's session, and I will hand over the mic to Dr. Kedar, sir. Welcome, sir. And you can start the session for today's program, sir. Thank you, sir.
Thanks, Gunadhar, and thanks, Akhilesh. And nice to see our old colleagues back, Rishi and especially Jayant, who I used to meet every year for the ultrasound program. But because of the COVID stuff, we couldn't meet. But hopefully this year we'll be meeting for the best of Brussels. So without much ado, I'll start off. So lungs are a major hindrance for the ultrasound at thoracic level. This was said by Harrison, Principles of Internal Medicine, 1992, and obviously this was simply wrong. And this was a man who was responsible to prove that or disprove that. So Daniel Lichtenstein was an intensivist and father of ultrasound and intensive care, and he has penned this book, which is Whole Body Ultrasound and Critical Care. And those who are connoisseurs for critical care ultrasound, this is a must read and a must in your library or in your PDF. So this man is a genius. I had the privilege of meeting him a couple of times. He's a live wire, and I personally feel he deserves a Nobel Prize for this. So what are the limitations of chest X-ray? It's difficult to ensure breath holding. It reduced spatial resolution is there. It is incorrect assessment of pleural effusion consolidation or alveolar interstitial syndrome when you see an X-ray like this in your ICU, and it's not uncommon to see an X-ray like this in your ICU every time. So sensitivity in detecting pneumothorax is around 53%, not great. Accumulation of air in the pleural space anterior to the lung in supine position may be also difficult. And in mechanically ventilated lung, it may be still difficult to know the presence of pneumothorax. So why ultrasound? Obviously easy to learn, non-invasive, rapid, repeatable. All of us know this. It is easier and faster than an X-ray chest. So if you see the downtime of getting an X-ray chest and seeing the film is almost 10 to 15 minutes or maybe more. So 10 to 15 minutes is by good standards. But if you see smaller centers, it's much more. Even if you have an X-ray machine in your department in the ICU itself, it takes more than 10 minutes to get the X-ray done. Now, detection of pleural fluid as little as 100 ml can be picked up by ultrasound. It's more sensitive and specific for pneumothorax and pulmonary edema, especially alveolar interstitial syndrome. So this slide tells you the value of ultrasound in different pathologies. Now you take pleural effusion, the sensitivity specificity is 97% with ultrasound, whereas CT is 94%, less than the ultrasound. And this has been proved by various studies and various papers in the best of the best journals. Alveolar consolidation, 90% for ultrasound, whereas it's 98% here. In alveolar interstitial syndrome, it's the same 100% both ways. Complete pneumothorax, 100% for ultrasound, whereas 91% for CT. And occult pneumothorax, it may not be as good. It is 79% for the ultrasound, whereas 100% for the CT. So if you see the comparative diagnostic performance of auscultation, chest radiography, and ultrasound, obviously you see that the sensitivity is much better. The diagnostic performance is much better with ultrasound. With auscultation, it is for pleural effusion, it's 42%, whereas for chest radiography, it's 39%, whereas lung ultrasound is 92%. Sensitivity. Specificity is 90%, 85%, 93%. Alveolar consolidation, it is 95% for chest radiography, ultrasound is 100%. And again here, alveolar interstitial syndrome, here it scores above obviously the chest radiography and your auscultatory findings also. This was published in Anesthesiology 2004. Now this slide tells you that it shows you a earth-sky interface. And why is it important? It's important because lung ultrasound basic works on the earth-sky interface. So lung is an intermix of air as well as fluid, and different pathologies are intermix of air and fluid in different proportions. So if you see this, the air to fluid ratio, if you take it as, if you take a pathologic like a pneumothorax, it will be 100% air. Okay, if it is a complete pneumothorax, whereas normal lung is 99% air intermixed with some fluid. If you start with alveolar interstitial syndrome with early interstitial edema, it's 97% of air but 3% of fluid. And as the fluid part goes on increasing, it becomes 95%. And if it is a consolidated lung, it's more of fluid rather than air. So 90% is fluid, which is the inflammatory fluid in pneumonia, or it can be just fluid in hemodynamic pulmonary edema. In atelectasis, it's just 5%. And in pleural effusion, it's all water or all fluid and no air. So this is the spectrum of the disease status, a normal lung and different pathologies in which you have an intermix of air and fluid. That's why this analogy of air-sky interface or air-sea interface rather. So if you see the ratio, pneumothorax is all air, no fluid, ratio is 1. Normal lung surface, the ratio becomes 0.98. Early alveolar interstitial syndrome, it becomes 0.95. Consolidation, it becomes zero point 0.2 or 0.1. And obviously pleural effusion, it becomes 0 because it's all fluid and no air. So what are the 7 principles of lung ultrasound? I'm going into the basics of lung ultrasound, so you may not falter on whatever advanced things you may have to decipher later on. So the first and most important principle is it requires a simple 2D apparatus, which is the most. You don't require a high-end machine because lung ultrasound is everything about artifacts. So you don't require a high-end machine. In fact, you have to switch off your filters. Thorax is an area where air and water are associated. We just discussed that. And of course, in a normal lung also and in pathological lung also. The lung is the largest organ in the body if you see surface area wise. All the signs arise from the pleural line. That's very, very important. That's why identifying the pleural line and knowing whether it is sliding is very, very important. Lung signs are basically based on analysis of artifacts. So lung ultrasound is everything about artifacts, okay, and how do you interpret those artifacts. Lung is a vital organ and most signs are dynamic. So lung sliding is very, very important, okay. So that's very, very, so it's a dynamic organ. And nearly all the acute disorders of thorax come in contact with the surface. That's why Dr. Daniel Lichtenstein illustrated the lung ultrasound. So it's based on the principle of bat sonar. So it's based on the principle of returning of the sound waves and the artifacts. So this is what you see in lung ultrasound. So you don't know what is the real image and what is the true image. So you have to know what are the artifacts, what is the true image, and then interpret the image accordingly. So this is our superstar Rajnikant and Talaiva. So we need this Rajnikant on the right side, which is a true image, and not this. And I really really idolize this gentleman here because he is not afraid of showing his true image in the public, and that's what lung ultrasound is about. So you have to have artifacts in the ultrasound. So unedited images are important. You don't require any filters. So switch off all your filters, switch off the multi-beam technology, no image enhancers. That's very, very important. And that's why even a baseline machine works wonders in lung ultrasound. So these are the 10 basic signs which I would go through today. And all these signs are very important to get the hang of lung ultrasound. And mastery of these signs allow control of multiple settings, which can be ARDS management, which can be hemodynamic therapy in a shock patient or trauma patient or whatever. So on and so forth. So the first sign is a bat sign, followed by the A sign, followed by the lung sliding, the cord sign for pleural effusion, the sinusoid on the M mode for pleural effusion, then the tissue-like sign for consolidation, the shred sign for consolidation, the B lines, which are the lung rockets, the stratosphere sign on the M mode in pneumothorax, and the lung point, which is a diagnostic sign for pneumothorax in lung ultrasound. So the machine, as I told you, you require a simple machine. You don't require a high-end machine. And the probes which are required are twofold, or you can use all the 3 probes. So I personally like the micro convex probe. but microconvex probes is not available everywhere. So if you ask me one probe which you can use for any ultrasound, point of care ultrasound, it's a microconvex probe, which Dr. Daniel Lichtenstein loves. But you can do with the cardiac probe, which is the phased array probe here. So this is used. This can be used for the lung ultrasound. And if you want to see the pleura and the superficial structures, you can use the vascular probe, in which the frequency is slightly higher, 6 to 15. So if you want to see the pleura better and the skin and soft tissue better, you can use the superficial probe. But I personally like to use the phased array probe or the microconvex probe because it makes things easier. And of course, if you want to do certain procedures like pleural tapping or want to see the diaphragm better, then only I use the curvilinear probe, which is the abdominal probe, same frequency as the phased array probe. So I use this curvilinear for the diaphragm. Okay. Today, I'm not going to discuss on the diaphragm, but specifically this probe can be used for the diaphragm. So this is a microconvex probe which Dr. Daniel Lichtenstein uses. And why this microconvex? Because it can go in the intercostal spaces anywhere, okay, in the body. And of course, you can even use this for vascular cannulation also. Otherwise, if you can't use the phased array for vascular cannulation. So this has a depth of 35 centimeters, a smaller footprint, lower resolution, okay. And of course, the linear probe, which I told you. So this is an excellent probe to visualize the pleura and the skin and the soft tissue. So where do you locate, where do you put your probe, where do you insonate? So Dr. Daniel Lichtenstein has given blue points as standard examination points. So this is upper blue point. So if you put your palms, okay, if you put your palms on the patient's chest, then this point here, which you can see the upper red point here, is the upper blue point, which is the base of the ring finger and the middle finger here. The lower blue point is here, which is the base of the dorsum of the palm here. Okay, that's the lower blue point. The little finger, okay, little finger of the lower hand, okay, is the phrenic point here. So the lower part of the little finger is the phrenic point here, and the phrenic point, which intersects the and mid axillary line, is your phrenic point. So the phrenic line, if you extrapolate the phrenic line to the mid axillary line, that's called as a phrenic point. Okay. Further, this is called as Plapp's point. So if you extrapolate the lower blue point, so I go again here, this is the lower blue point here. This lower blue point, if you extrapolate and if it intersects the posterior axillary line here, that is called as a Plapp's point. Now, why Plapp's and what is the full form of Plapp's? Plapp's is posterolateral alveolar pleural syndrome, in which you see pleural effusions and lower part of the lung posteriorly better. Now, why this Plapp's? Because most of our ICU patients are lying down supine. It's very difficult. Sometimes it may be very difficult to turn them unless and until they are in a prone position. Okay, like when you are proning these patients for AR days, which we saw in COVID era, last couple of years, which we saw that patients were prone, then it becomes easy. But otherwise, Plapp, the posterior part of the lung is missed out if you don't insonate the Plapp's point. So Plapp's point is also very, very important. So we have the upper blue point, we have the lower blue point, we have the phrenic point, we have the Plapp's point, and we have the phrenic line. Now, the Britishers or the Americans have plagiarized the blue points into zones. So this is zone or quadrant. So this is zone 1, that is anteriorly here. Then this is zone 2. This is the parasternal line, this is the anterior axillary line, and this is the posterior axillary line. So zone 1 is anteriorly here, down below is zone 2. Here in the axilla is zone 3, superiorly, inferiorly it's zone 4, and 5 and 6 are posteriorly. Similarly, Dr. Lichtenstein has 2 prone points. One is in between the interscapula. So interscapularly, the midpoint of the interscapula on each side is your upper prone point, and lower prone point is the tip of the scapula, is the lower margin, inferior tip of the scapula. So whichever way you want to insonate, you can use whatever cementology you want or methodology you want. I personally use the blue points because why blue points are important. Phrenic point, for example, if you want to insonate the diaphragm, you go directly on the phrenic point, or you want to insonate something which is posterior, you go on the flaps point. You want to insonate for a pneumothorax, you go on the upper blue point. So that's why the blue points are easy to remember, and you can target your pathologies accordingly. But of course, you can use the American nomenclature, which is one quadrant, 1, 2, 3, 4, 5, 6, which I said. Now let's come to the first sign, which is a bat sign. So first and foremost, you have to identify the ribs. So if you see this, so you can insonate the pleura. If you can insonate the lungs vertically also and horizontally, but by methodology, you have to first start vertically. So if you want a deeper insonation and you want to know more about the intercostal spaces, you can put the probe in the transversal direction. But by rule, you put it in the longitudinal direction. So this is longitudinal, this is cephalic, this is caudal. So you can see the two bat wings here. These are the two bat wings here. So this is called as a bat sign. These are the rib acoustic shadows here. So these dark shadows are the rib acoustic shadows down below. Okay, they are not pleural effusions. The pleural line and the upper and the lower rib make a permanent landmark, and this bat sign is a basic step to locate the lung surface in any circumstances. So why bat sign is important? Because you have to identify the pleural line. So the pearly white line which moves with respiration and which has inherent sliding capacity is called as a pleural line. Okay, so this is the hyperechoic line. So the first line, which is horizontal and which slides with respiration just below the bat sign, is your pleural line. So the bat sign is important to identify the pleural line. That's very, very important. So next come to lung sliding. So lung sliding, the pleural line normally separates two distinct pattern in the M mode. So if you put a M mode on this, if you put a M mode on the lung like this, you will see something called as a seashore sign. Okay, we'll come to that. I'll tell you how the seashore looks like. So let's come to this video. So you insonate in the vertical direction, okay, semantologically, and you see this. So that's the pleural line. This is the bat sign. So one rib, the second rib here. Okay, again going back. So this is a vertical insonation. This is cephalic. This is caudal. Okay, so you can see this. This is the pleural line which moves with respiration. Okay, and it is hyperechoic and pearly white. And these are the two ribs. So this is the bat sign. So this is one rib. This is the other rib. These are the rib acoustic shadows down below. This is the chest wall. Okay, so this is the chest wall sector. This above the bat sign. Then you have the rib sector. Then you have the pleural line, which is the pleural sector, and then you have the subpleural sector. So anything below the pleural line is artifactual ultrasound. So pleural line and anything below that are artifactual images, whereas the chest wall, okay, and everything above that, so the skin, soft tissue, and the chest wall, the muscles, and chest wall are real-time images. Okay, so this is how it goes. I'll again run the video. So you can see the sliding very nicely here. And when you put an M mode on this, then this is again the B mode in which you see the A lines. So this is the pleural line here, and you can see horizontal lines which are parallel to this pleural line. So this is these are called as A lines. So I'll come to the A lines again. Now, how does ultrasound interact with air? Air behaves as a highly refractile mirror, and whenever ultrasound beams encounters a tissue-air interface along its path of the beam, they're unable to penetrate. So what they do is, instead of giving you a real image, they give you a reverberation artifactual image or a mirror artifact image. So if the ultrasound hits one sector here, it again reverberates. It goes down and hits, and again comes back here. It goes down and hits another depth. It again comes back here. So what you get are called as reverberation artifacts, and air behaves as a highly refractile mirror, and this mirror can give you images, artifactual images at different levels, and these are called as reverberation or mirror image artifacts. Now, what does absence of sliding mean? So why do you have sliding? Now, sliding is because of the viscoelastic properties of the pleural fluid, and sliding is because the lung, when the lung is expanding and relaxing, you get a movement on the pleural line. So that's why you get sliding. And if the sliding is absent, then these are the things which you can think of. So if the sliding is absent, then you can think of a pneumothorax. The pleural fluid is replaced by air. You can have massive atelectasis in an obstructive atelectasis. You can have a mainstem bronchus intubation similar. So because of the right main bronchus intubation, the left lung is completely non-aerated. You can have pneumonia in which you have absence of the lung sliding because of the involvement of the pleura. And of course, apnea. If the patient is not breathing or is dead, you won't get sliding because the lung doesn't move. And of course, post-pleurodesis, if the pleura is stripped and the pleural fluid is no longer there, so again, you won't get sliding. So the first question to be asked is whether the sliding is present or not present. And if the sliding is absent, you think of all these pathologies. So let's come to the A line now after the sliding. So A line is nothing but the reverberation artifacts arising from the air in the lung. So whether it is physiological air or pathological air, it's going to give you these reverberation artifacts which are called as A lines. Okay. So A stands for air, whether it is physiological or pathological, A stands for A lines. And A lines are horizontal lines which are equidistant from the skin soft tissue to the pleural line. So this distance is equivalent to the other A line to the other A line, and whatever you are seeing in between are again more reverberation artifacts which are called as A dash lines or A prime lines, or some people call it as A2 lines or A1 lines, or whatever you can call. Those are semantic things. So A line stands for repetition of the pleural line. These are horizontal, these are hyperechoic lines. These come from air blocking the ultrasound beam, and it's seen in normally aerated lung. But if the sliding is absent, you can see A lines also in a pneumothorax, which is called as a A line sign. Okay. So whether it is physiological air in a normally aerated lung or a pathological air in a pneumothorax, you will get A lines. But the difference between those will be in a normally aerated lung, the sliding will be present, whereas in a pneumothorax or an abnormal air, whether it is a bulla or whether it is a pneumothorax, or a cyst, underlying cyst, you may get absence of sliding. Now, reverberation artifacts, again, horizontal to the pleural line, separated by regular intervals, seen in normal aerated lung. And you can also see it in asthma COPD, because here the parenchyma is normal. It's an airway disease. So you, again, in asthma and COPD, the patient is breathless, you will get A lines. You won't get B lines here. Now, these are how A lines look. Again, I won't go, you have seen the video. This is a repetition of the video. So again, that's one A line, then again, one more A line, one more A line. And this is equidistant from the skin and soft tissue to the pleural line. Now, this is called as a seashore sign. So when I put my M mode on the pleural line here in a normally aerated lung, you see the C part of it on the M mode, okay, which is the skin and the soft tissue, okay, which is generally immobile. Whereas you can see the pleural line here, which demarcates the sea and the shore, okay, and the sandy beach is an analogy for the air in the lung. So these are the artifactual images. The sand is the artifactual image, and that sand is demarcated from the sea by the pleural line here. So whenever you want to appreciate sliding again and you want to make sure that sliding is present, put the cursor on the M mode and run the M mode, and you will see the seashore sign. Okay. And if you want to decipher the seashore again, that's the B mode. So everything above the pleural line are real-time images here. So the skin, the muscle, then the pleural line, and below the pleural line and below the pleural line are artifactual images. So that will be your sand. Okay. So this is the skin, which is seen as the waves, the muscles again, which is the ocean, the pleural line, which demarcates the sea from the shore. Okay. And of course, the lung artifacts are the sand on the beach. So this is how you decipher it. So again, let's come to the next artifact, which is again very important, which is called as a comet tail artifact. This is an ultrasound sign of alveolar interstitial syndrome. And Dr. Daniel Lichtenstein struggled for almost more than 17 years to get this published. In fact, he was harassed by most of the American journals, and they didn't accept his work initially, saying that it is all humbug. but finally they had to accept it, and it took him almost 15 to 17 years to publish this paper, and a path-breaking paper here. So why do you get B lines? So normal ultrasound process is this, that each septum gives an image that is more echoic than the alveolar content. So whenever you see a septum, it will give you a more echoic image on the ultrasound. And when these septae are filled with alveoli and the interlobular septae are seen simultaneously, you get an alveolar interstitial syndrome. So if in a normal lung, you don't see B lines, you see A lines because it is normally aerated. But when you get fluid in the lung, it is a pathological fluid in the lung. For example, alveolar interstitial syndrome. When it starts off, you see the intralobular septae which are fluid filled. And then when the edema increases, the interlobular septae may be fluid filled. And this is seen as the B lines. Now, B lines are also called as lung rockets, and they imply that you have interstitial syndrome. And the most important thing is B lines denote deaeration. So whenever you have B lines, that means the lung is deaerated. Now it can be deaerated because of fluid. It can be deaerated because of a collapse, okay, or it may be deaerated because there is an obstructive collapse, as you see in a right main bronchus intubation. So these are all places where you can get B lines. So how do you differentiate them from each other? We'll come to that later. But diffuse lung rockets at 4 point of the anterior chest define pulmonary edema. So they have to be at least 3 or more than 3 B lines, okay, in the two interspaces. That defines interstitial syndrome. Now these B lines are called as comet tail artifacts, okay, and comet tail artifacts, B lines are one of the comet tail artifacts. You have other comet tail artifacts also, which are called as E lines. And what are E lines? E lines are again vertical lines which you see, but they emanate from the skin and soft tissue. They do not arise from the pleura. So all the vertical lines which arise from the pleura and go right down across are B lines, but E lines arise from the pleura. Again, they are because of air in the subcutaneous tissue or in the skin and the soft tissue, and they are called as emphysema lines. So the most common example or the common cause for E lines is subacute emphysema, and again that air alveolar interface is in the skin and soft tissue and not below the pleura here. You can also see certain lines called as Z lines. These lines don't reach the bottom, and that's how you can differentiate them from the B lines. They are again artifactual lines. They are not important. So E lines are important. E lines suggest that it can be subacute emphysema. The other reason for E lines can be a pacemaker or metallic objects. You have a trauma or you have a bullet injury and the metal struts are in the soft skin and soft tissue, then you can get E lines. Or you have a pacemaker, you have a pacemaker implant there and that generator is there, that can give rise to E lines also. Now, comet tail artifacts is a broad spectrum to tell you about the vertical artifacts, and B line is a part of the comet tail artifact. Okay, so is the E line and so is the Z line. So how do you define B lines? B line is a comet tail artifact. It arises from the pleural line. It doesn't arise above the pleural line. It is well defined and laser-like. It is hyperechoic. It does not fade till the end of your image. It erases the A lines completely and it moves with lung sliding. So all these 7 features are very, very important to know whether they are B lines or no, or whether they are some other comet tail artifacts. Now again, this is B lines denote deaeration, as I said. So whenever the lung is deaerated, whether it is because of fluid in the interstitium or whether it is because of a collapse, okay, that denotes deaeration. So causes of B lines can be alveolar interstitial syndrome, which we commonly see in cardiogenic pulmonary edema, interstitial lung diseases, interstitial pneumonias. COVID was a time when we saw a lot of B lines with a break in the pleura, with thickened B lines, with subpulmonic consolidations. So COVID gave us a completely different spectrum. We had flashlight blue lines, flashlight blue B lines also. You can have B lines in obstructive collapse, or you can have it in collapse consolidation with a non-patent bronchus. So this is all about B lines. Now this is how B lines are generated. So you put the probe here and there is fluid in the interstitium here, and that fluid will appear as a hyperechoic line. Okay, these are the hyperechoic lines, and it will move with respiration, and it will will be arising from pleura. Generally, B lines represent alveolar interstitial syndrome, but you can get B lines in different categories. Now, how do you categorize B lines severity wise? If there is only single B line, it is not pathological. It can be because of the fissure also. If there are three or more than three lines, three B lines in between one intercostal space, they are significant. Okay, if they are 3 millimeters apart, they are more significant because it tells you that the pulmonary edema has increased. If they are 7 millimeters apart, like in this image here, it tells you that it's early interstitial edema. And as the interstitial edema progresses, the fluid part becomes more and more, you will get B lines which are nearly spaced. So instead of 7 millimeters, they will come to 3 millimeters. So that's called as B7 and B3, and a small b here. Small b means a single B line, which is not significant. Now, mind you that posterolateral B lines also can be seen in some normal individuals, especially elderly people. Like we say that curly B lines can be normally be seen in elderly individuals at posterior basal regions, but you have to go clinically. Of course, you can have paracardiac B lines, which can also be normal. So don't misinterpret those paracardiac B lines to be abnormal B lines. Now, this is no B lines here, A profile. This is single B line. This is a fissure, 2 B lines, 3 B lines, 5 B lines, and whiteout. So when the B lines coalesce from B3 profile, they will give you a whiteout picture, which you see as a gross pulmonary edema or a white lung on the X-ray. So those are called as a Birule pattern by this Birule word is coined by Dr. Daniel Lankenstein. And this is a B profile. Again, this is a B3 profile in which the edema is significant here. And if you see more florid edema, it will be coalescing B lines here. So this is a coalescing B lines. Those B lines are coalesced. This was a COVID patient in our hospital. So these B lines have coalesced because of Birule pattern here. So again, one more picture of coalescing B lines. So this is seen as a whiteout X-ray. So you can see that these B lines are coalesced and it's like a storm appearance or a sandstorm appearance here. So this is classically a thickened pleura. You can see that the pleura is not smooth here. Okay, the pleural line is not smooth. It is wavy and there are breaks in the pleural line. And you can see subpulmonic consolidations here. Those hypoechoic shadows just below the pleural line are subpulmonic consolidations here, which we could see in the COVID-19 patient. Of course, this is one of patients with COVID-19 here with B lines here. So this is classically interstitial pneumonia and COVID. A differential diagnosis, of course, can be any interstitial pneumonia. It can be H1N1 or any other interstitial pneumonia. So how do you differentiate between different B lines and cardiogenic edema versus chronic heart failure versus ALI-ARDS and pulmonary fibrosis? So clinical setup, cardiogenic pulmonary edema is acute. You have B lines number which are significant. Distribution is bilateral, diffuse, and they are homogeneous and symmetrical. Other lung ultrasound findings can be pleural effusion in cardiogenic pulmonary edema. You get bilateral pleural effusion, and echocardiography is obviously abnormal. So in chronic heart failure, the clinical setting is chronic or acute. On chronic, B lines may be lesser in number as compared to acute cardiogenic edema. It will be multiple diffuse, may follow the decubitant region. Of course, pleural effusions may be present and echocardiography will be abnormal. In ARDS, like you saw the COVID lung or COVID ARDS or any other ARDS, this is again acute. The B lines are many in number. They are non-homogeneous. Okay, this distribution is non-homogeneous, and there is presence of spared areas. That's very, very important. You may have pleural effusions, you may have alterations, you may have consolidation also, and the echocardiography will be normal here, obviously in ARDS. Some patients may have cor pulmonale because of ARDS. In those subsets, you may get a RARV dilatation. Okay, in pulmonary fibrosis, it is acute chronic setup. The B lines may vary from being very less to more depending on the spectrum of the ARDS, of the pulmonary fibrosis ILD. These B lines are more frequently at the posterior lung basis, and there is pleural thickening as you see in ARDS also. Echocardiography again will be normal here. So this is how you differentiate different disease spectrum based on the B lines. Of course, B lines for acute cardiogenic edema Sensitivity is as good as 94%, specificity is 92%. And this is one of the pictures in which you have cardiogenic edema here, and this is interstitial lung disease here. You can see that these are more homogeneous, symmetrical, okay, follow a pattern. These are non-symmetrical, lesser, and there is a break in the pleura. Can you see that break in the pleura? Okay, so this can also be seen in interstitial pneumonias like COVID. If you compare thoracic ultrasound with PA catheters, A-line predominance tells you that the wedge pressure is less than 18. Whereas if you have B predominance, there is no conclusion about the wedge, but A-lines has a very good negative predictive value to tell you that it's a dry lung, and the specificity is as good as 93%. Sensitivity may not be as good, 50%. So it almost has ultrasound has almost made Swan, which was already obsolete, more obsolete. Of course, now we come to consolidation, which is the next sign. You have a transglobal consolidation, which looks like a tissue-like sign, whereas a non-transglobal consolidation looks like a shred sign. So what is tissue-like sign and what is shred sign? So tissue-like sign is hepatization of the lung. So lung looks exactly like the liver or the spleen on the other side. So it looks like a tissue here. So the lung, the air is replaced, the alveoli are replaced by inflammatory fluid, and it looks like a tissue. So that's called as a tissue-like sign. Okay. Or you have a shred or a fractal sign. So shred sign, if you want to see why you get a shred, if you see in a shred sign, it's more peripherally as compared to tissue-like sign, and you get the consolidation which is at different levels. Okay, so if you are seeing the pleural line is shredded like this, and not only that, you have different areas of the shred. So you get the inferior margin as one, this is the superior margin, this is the deeper margin here, and you see that they are like shredded papers. That's why it's called as a shred sign or a fractal sign, and it is seen in the non-transglobal consolidation. So this is the tissue-like sign again, and that's the shred sign. So instead of a lung line here, you get a shredded line here. Okay, so that is called as a shred sign, and the white part is actually the lung. So it's hyperechoic shadows are the air. Okay, so that's the air, and that's the consolidated lung there. So this is the deep border is shredded here, and it's typical of non-transglobal consolidation. The pleural line or lung line divides it into superficial and the deep borders, which I just mentioned. Again, one more view here. So what is this? Can you appreciate some dynamism in the air bronchogram, in those white shadows here? So you can see that as the lung is expanding, okay, and moving, you can see white specks of hyperechoic shadows here moving across to and forth with respiration. This is called as a dynamic air bronchogram. You can see some pleural effusion also here, and this is a classically consolidated lung which is seen in the parapneumonic effusion. Okay, and what you are seeing is the air moving through the consolidated lung. So that is called as a dynamic air bronchogram. And if you see this pattern or if you see this clip, you can be sure that this is alveolar consolidation. So this is a consolidated lung. And here you have to have a patent bronchus to get this. Not always you can get this dynamic air bronchogram. If you don't get this, if it is a non-patent bronchus, then you will get a shred sign. So if you're lucky and the bronchus is patent, you will get this dynamic air bronchogram. And what hyperechoic shadows you are seeing is actually the air. So the air bronchogram looks exactly the opposite on the X-ray. The air bronchograms look black. The air looks black on the X-ray, whereas the consolidated lung looks white. Here the air bronchograms look hyperechoic or white on the ultrasound, and they move with expansion and relaxation of the lung. One more ultrasound image which shows you the break in the pleura. So this is again, these are the rib acoustic shadows here. That's the pleural line. The pleural line is not, there is no sliding, and you can see that the pleural line is not regular. It is shredded. It is broken at places. And again, one more image of a COVID lung, in which you can see subpulmonic consolidations and C lines also here. So these are called as C lines, curvilinear lines here, are called as C lines, which represent the subpulmonic consolidation. So you can see the B lines also here. So let's come to pleural effusion. In pleural effusion, the ultrasound B mode sign is called as a chord sign. Chord is the image between the pleural line here and the shadows of the ribs. So this forms a chord or a quadrilateral. And you have a deep border also and a superficial border. So the deeper border is called as a lung line. And in between the lung line and the pleura is your pleural fluid here. So the parietal and the visceral pleura is separated by the pleural fluid. So this is called as a chord sign on the ultrasound. And if you put a M mode on the chord here, you will see something called as a sinusoidal sign. This is because of the inspiratory movement of the lung line towards the pleura. So this is called as a sinusoidal sign, and it is very specific for pleural effusions, even smaller effusion. The only place where you won't get a sinusoidal line in the pleural effusion is the pleura is very, very thick. If the pleural fluid is very thick, so it's an empyema or it's very thick fluid, and the underlying lung is not moving because of adhesions, then you may not get this sinusoidal sign. Otherwise, you can see the sinusoidal sign very well, and you have to put the M mode on the chord sign to know whether it is a sinusoid, to know whether it is a pleural effusion. So this is again the B mode in which you are seeing the chord sign here, and you put the M mode on this chord and you see the sinusoidal sign movement of the underlying lung, okay, during inspiration and expiration here. So again, this is how you perform ultrasound examination of pleural effusion. Put your probe on the phrenic point. Now here I'm using the curvilinear probe because I want to see the deeper structures. I want to see the diaphragm. So this is the diaphragm here. That's the spleen. That's the kidney here. That's the superior part. That's the inferior part. And this anechoic shadow here is the pleural effusion here. Okay, that's the pleural effusion here. So now this is again called a jellyfish sign. You can see the lung which is collapsed, floating like a jellyfish here. Okay, that's called as jellyfish sign. That's the pleural effusion here. That's the diaphragm here. That's the liver below here. So again, this is one more image. You can see the pleural effusion. Now you can see here that you can see fibrin here, and you can see the consolidated lung here. You can see the shredded lung here. Okay, that's the collapsed lung which is shredded. You can see the hyperechoic areas and shred sign nicely. You can see the diaphragm and you can see the fibrin here. So whenever you see fibrin or dots like this here, you can see the hyperechoic dots here. That's an exudative fluid. Now, clear fluid does not mean that it is transudative every time. Clear fluid can mean that it is exudative or transudative. But if you see fibrin or if you see planktons which are hyperechoic dots floating in the pleural fluid, it is definitely exudate. It can be blood, it can be empyema, it can be an exudative fluid again. Okay, so that is how you collitate the pleural fluid. And this is one example of a complex septated effusion. This is a CT image and this is an ultrasound image. You can see the septate here. And of course, again, whenever you want to quantify the fluid, you have to measure this border. So this is the end expiratory collapsed lung. Okay, that's the end expiratory collapsed lung, and you measure it from the upper dome of the diaphragm here. So the separation in millimeters of the end expiratory collapsed lung, okay, to the diaphragm in millimeters multiplied by 20 is your rough calculation for fluid quantification. So if my separation is around 10 millimeters, then it is 10 multiplied by 20, that is 200. If it is 20, it's 20 by 20, it's 400. So on and so forth. So you can roughly quantitate how much fluid this is. This was published in Intensive Care Medicine in 2006, and this is an easy formula to understand. Or you can have a semi-quantitative assessment in which the end expiratory distance from the fifth intercostal space, if it is more than 50 millimeters, then the fluid is around more than 500 ml. And if the end expiratory basal interpleural distance is more than 45 millimeters, or okay, then it is around 800 millimeters. So there are different methods of quantifying pleural effusion. You can use the semi-quantitative method or the other method which I just showed you. Now, what are the criteria for safe thoracocentesis? The pleural effusion should be definite, so you should have a chord sign, and when you put the M mode, the sinusoid sign should be elicited. The interpleural distance should be at least 15 millimeters at 3 adjacent intercostal spaces. That's very, very important. You have to avoid other vital signs like heart, liver, spleen apart from the lung itself. And of course, you have to go at the upper border of the lower rib, because the neurovascular bundle is at the lower border of the upper rib. In a static position, and you have to be sure in a static technique, when you are not doing a real-time ultrasound, you have to be very careful about the respiratory variations and the position of the patient. So by this, you cannot make many mistakes in thoracocentesis. Now let's come to the last but not the least sign, which is the pneumothorax. There are 3 signs. One, and first and foremost, is abolished sliding. So I told you that whenever you have any pathology in the pleura, whether the pleura is filled with air or fluid, the sliding will be absent. Okay, so the first and foremost thing in diagnosis of pneumothorax is absent sliding. Now, does only absent sliding tells you that it's a pneumothorax? No. What else do you want to see? You will see that there will be a A profile. Okay, so absent sliding and you see a profile, then that's called as a A-line sign. Okay, and if you put an M mode on it, you will see this. This is called as a stratosphere sign. So the seashore is replaced by the stratosphere sign. So the sand is replaced by the sea again, and you see all lines. Now this is also called as a barcode sign. The old barcode, the new barcodes don't look like this. The stratosphere looks like this, because if you see the stratosphere or the jet exhaust, when a jet is going in the air or in the sky, you see something like this. Okay. Now, does a stratosphere mean that it is definitely a pneumothorax? No, it doesn't mean that it's a pneumothorax. It will tell you that it is just abnormal air below your probe, ultrasound probe, in that region or that zone or that dew point. Now, to be very sure that this is a pneumothorax, what you do is you have to come to a conclusion that there is a lung point. So what is a lung point? Lung point is a transition zone of the collapsed lung, okay, and a lung which is expanding, okay, or the expanded lung which is down below. Now you can see when you put a M mode on this, you can see a stratosphere and a seashore sign coming intermittently. So whenever the patient is inspiring, the lung is expanding, your collapsed lung is going to reach the surface, okay, for some time, and that's going to give you a seashore sign. And when again the patient expires and the collapsed lung again goes back, you are going to see the stratosphere sign. So this is called as a lung point. I'll tell you how the lung point looks like. So this is a small pneumothorax here anteriorly. You put a probe here, okay, and that's the parietal pleura. The red line is a visceral pleura here, and that's the intrapleural air. So you will see that there won't be any sliding. The sliding will be absent here, and you will get, if you put the M mode on, you will get a combination of seashore and stratosphere. Okay, so this is again one more video in which you see that you can see the sliding here, and the sliding is absent here. Okay, so you can see the sliding present and absent here. This is one more image, and you can see the sliding very nicely here, but here there is no sliding. So this is definitely a lung point on the B mode. I'll show you one more image here. You can see this very nicely. No lung sliding here, but you can see the pleura sliding here. So this is a lung point on the B mode. So again, one more lung point. This area is sliding here, pleura is sliding, and there is absence of sliding here. So how do you go about the algorithm of a pneumothorax? Lung sliding, if it is absent. If it is present, the pneumothorax is ruled out. So negative predictive value for a pneumothorax when the lung sliding is present is 100%. Similarly, if the sliding is absent but you get B lines, that means pneumothorax is again ruled out. So you have 2 good negative predictors for ruling out pneumothorax. What are those? Presence of sliding and presence of B lines. Why presence of B line? So a wet lung can't be a deaerated. So if you see B lines there, okay, that means the pneumothorax is 100% ruled out. And obviously, if there is sliding, there can't be a pneumothorax. Okay, so if the sliding is absent and B lines are present, pneumothorax is ruled out. But if the sliding is absent and you see only A lines, that is called as the A line sign, then you have to confirm it with a lung point. Now, sometimes you do not get a lung point if the pneumothorax is big because you don't see a interface between the collapsed lung and the aerated lung. So here, then if there is no lung point, then you can use the other tools like a CT when it is under, when your diagnosis is under cloud. So this is the algorithm for pneumothorax. So what is this? What is different in this? If you can see this, you can see here that the sliding, instead of classical sliding, you can see pulsations here, and those pulsations are transmitted to the pleural line here. Now this is called as a lung pulse. Okay, this should not be confused with the lung point. This is called as a lung pulse. What is a lung pulse? If you put a M mode on this, okay, on this, on the ultrasound image here, you can see the pulsations, cardiac pulsations, which are transmitted here till the pleural line, and this will follow the pulse of the patient which you are monitoring. Okay, so this is in periodicity to the pulse, and this is called as a lung pulse. So it is a sign of immobile lung with characteristic transmitted pulsation of the heart. And when do you get a lung pulse? When you have a patient who is apneic, or there's an endobronchial intubation, and the left side is a right bronchus intubation, brainstem intubation, and you get a lung pulse on the left side because you get a cardiac transmitted pulse because of atelectasis, and that's a characteristic sign which you see in early atelectasis. It may also be because of bronchial obstruction leading to the collapse of the lung. So these are the scenarios where you get a lung pulse. It is not supposed to be confused with a lung point. Lung point is seen in pneumothorax, whereas a lung pulse is seen in an atelectatic lung. So this is the difference. So if you put the M mode on the lung in a pneumothorax, you will get the stratosphere and seashore in cohesion. So you get stratosphere sometime and a seashore, stratosphere and a seashore alternately. Whereas in a lung pulse, you get cardiac transmitted pulsations, okay, which are synchronous with the pulse. So what is this? So this is a image for a rib fracture, okay, which you can very classically see here. There is a break in the cortex here, cortical break here, and you can use ultrasound to good effect for rib fractures in trauma protocol. So this is the image in which you are insonating. So the place where you have maximum tenderness, you can insonate there. You can insonate it vertically first, and then you can turn the probe horizontally later on. So this is how you do it. You go vertically, and then you can turn the probe horizontally later on once you know there is a break in the pleura. So this is turning the probe horizontally parallel to the rib, and you can see that there is a break in the cortex there. So again, one more example of a rib fracture. Now you can also diagnose sternal fractures on the ultrasound with good sensitivity and specificity. Now this is how you do that. So we had a patient, 74-year-old male, out of hospital VFRS, 10 minutes of CPR, return of spontaneous circulation, neurologically intact, occluded RCA. A linear probe was used, placed in the sagittal orientation after the CPR. And you have to trace, this is the sternum. Now this is not a sternal fracture, that is the manubrium sternum, that's the junction between the manubrium sternum here. Okay, that's not the rib fracture, that's the sternal angle. So there's a smooth direction of change here, so the direction changes here, so that's not the rib fracture. You go down below, insonate down below, and completely look at the lower border of the sternum. You can see a break in the cortex there. Can you see a break in the cortex? That's the sternal fracture. That's the discontinuity in the outline of the sternal fracture. And it can be used very nicely, especially in post-CPR or in trauma patients, which can be totally missed on the X-ray. So some clinical applications of lung ultrasound, you name it and you have it. Lung ultrasound is an integral part of all the ultrasound protocols, whether it is a blue protocol, whether it is a false protocol, whether it is a rush protocol. you name it and you have it. Okay, so you or whether it is a field protocol. So how does it help? It avoids referral to CT scans. It limits bedside radiographies. It decreases the radiation doses. It aids in safe procedures, especially thoracocentesis or blocks. It helps in the diagnosis of pneumothorax at the bedside and helps you to put in the ICDs. It helps in differentiating pulmonary edema versus other features. It helps to differentiate it, undifferentiated causes of breathlessness with the blue protocol, pulmonary embolisms, trauma, acute dyspnea, so on and so forth. So what is the stepwise protocol? So first and foremost is delineate which zone or blue point is scanned. So you have to name which zone or blue point or which part of the lung is scanned. So whether it is upper blue point, lower blue point, zone 1, zone 2, zone 3, zone 4, which part of the lung, which side of the lung, right lung or the left lung. Okay, then the next step is identify the bat sign, the rib and the costal sector, which I told you. So once the bat sign is identified, the skin and the soft tissue sectors also have to be identified, whether there's any abnormality, whether there are any E lines there. The pleural line then, whether the pleural line, identify the pleural line. The next question to be asked is whether sliding is present or absent. The next question to be asked is whether the pleural line is regular or irregular. The pleural line can be irregular, as I told you, in interstitial pneumonias or consolidation, where the pleural line can be irregular or thickened. Then the next step is the subpleural sector, which is the artifactual sector. In the subpleural sector, identify the profile. So if you have A lines, it's the A profile. If you have B lines, it will be the B profile. If you have C lines or consolidation, it will be C profile. And it will be a AB profile in which you may have B profile on one side or the A profile on one side, or sometimes it can be a non-A, non-B profile, also called as a COPD lung or asthma lung, where you say that it is a non-AB profile. Then you identify the profiles, as I said, screen the heart and the IVC, what is called as lung cardiac ultrasound, not just the lung alone. So the paradigm shift is that don't insonate only one organ alone. It has to be complete whole body ultrasound. Evaluate the diaphragm also. It is not in purview of today's talk. Diaphragm is a different lecture altogether. Okay, and of course fit into a clinical syndrome. That's very, very important. Your history is important, your auscultation and clinical examination is important. Do not omit that. That's very, very important. Change your therapy as per the inputs of your ultrasound aided diagnosis, and of course use history, clinical findings, biomarkers and other diagnostic tools for the same. And of course use USG to guide procedures to make them more safe and more successful. And what are the pitfalls? Rib acoustic shadows should not be mistaken as pleural effusions or something else. The depth is important. Okay, you have to go all the way down. Okay, and at the same time, when you want to see the pleura, you can use the vascular probe to delineate the pleura better. Screening all the blue points and zones is very, very important. If you do not insonate posteriorly, the lung ultrasound examination is not complete. You may miss out on posterior-basal pathologies like small pneumothoraxes or small pleural effusions or small consolidations or sometimes pleural infarcts also. Selection of the transducer for pleura, you can select the superficial, the vascular probe. For the deeper structures, you can use the phase array probe or the curvilinear probe. Now, of course, don't forget the heart and the other organs. Holistic whole body ultrasound is the key. I would ask for questions, but before that, one case scenario. Okay, so we had a 60-year-old male, known case of IHD, ASMI, LVF of 40% presented to the ED with sudden onset chest heaviness and dyspnea at rest around 20 minutes back. Also had history of fever with chills a day prior. On arrival, he was tachycardic, tachypneic with BP of 70 systolic. He was orthopneic with a saturation of 82% of the room air. ECG was suggestive of sinus tachycardia and he had fresh anterior wall ST depression. He had a bradycardic arrest in ED for which he was given CPR for almost 8 minutes, after which ROSC was achieved. Ultrasound was done immediately post ROSC. Ideally, it was supposed to be done during ROSC, but we couldn't get the machine down in time. And this was his lung ultrasound, right upper blue point. So what can you see here? Now, if you go step by step, again, right upper blue point here, You have the case scenario here, post CPR, and you can see that the skin and the soft tissue is not normal. You can see vertical lines here, which are arising from the skin here, down below. Those are E lines. So these are emphysema lines. So during the CPR, the patient had a pneumothorax and a subacute emphysema. And you can see that there is no sliding here, and you can see a pattern here. There are no B lines here. You can see subacute emphysema. You can see the absence of sliding here and A profile A line sign here. So this was a pneumothorax on the right side with a subacute emphysema. And the same patient on the left hand side in the lower blue point and the PLAPS point, we had this. So what's this? So obviously you can see some comet tail artifacts which are moving. Okay, and these are called as dynamic air bronchograms. So these are dynamic air bronchograms. You can see static air bronchograms also. You can see the shred and dynamic air bronchogram. So this patient also had fever and he had a classical pneumonia. It turned out to be a pneumococcal pneumonia on the blood culture. And of course, the right upper blue point showed this. If you can see again, there are E lines, presence of E lines here, but the pleura is sliding here nicely. And you can see flashlight blue lines here. So coalescing blue lines here. So he had a combination of pulmonary edema also in the lung, which was aerated on the left lung. And of course, this is the heart. You can see that this is the parasternal short axis. You can see that the window is not very good, but you can see that the heart is hardly moving. There are regional wall abnormalities. Anterior wall is almost akinetic. Some part of the posterior basal wall is moving there. So definitely a cardiogenic pulmonary edema here. You can see the apical ballooning here in the 4-chamber view here. There is apical ballooning and ejection fraction is severely reduced. And that's the IVC. IVC is full here, non-collapsible here. How do you treat? Of course, we put in the ICD, anti-LVF measures, targeted antibiotics after cultures. We put in a balloon pump, took him to the cath for a PTCA. We did a PTCA, but unfortunately, we couldn't salvage the patient. But here, the bottom line is that if you can have so many things in one single patient, but if your basics are good, you can use lung ultrasound and whole body ultrasound to good measure. So with that, I stop here because it's almost 1 hour. It may go on and on and on. So then we can have questions and the discussion with the panel. Thank you very much.
Yeah, thank you, sir. It's an
Thank you very
excellent
much.
presentation. I think you have covered almost everything, what is basic and what is needed for a intensive care perspective. So that is what is most important. Sir, we have few questions in the chat box, but before we go to the questions, I have actually 1 or 2 questions for all the other panelists. So to Dr. Jayant, sir, so the thing is that how can we use ultrasound in a patient with severe ARDS who is on ventilator, and how do you use ultrasound to decide our plan, like to do the proning, like for the weaning, or to put the patient on ventilator when the patient is on NIV?
Yeah. Now it's a very big question to answer, to be honest. So ARDS, let's go one by one. When you get ARDS patient, how do you, I will combine, there is a question somebody has asked about cardiogenic edema in ARDS along with your ARDS team. How do you differentiate between ARDS and cardiogenic pulmonary edema? Cardiogenic pulmonary edema, you will have a homogeneous P lines all over. Whereas if you have a ARDS patient, it will be non-homogeneous. At some places you will have normal lung ultrasound findings, and some places you will have lines, you will have irregular pleural line, you will have some shred lines. That is what a mixed picture is seen in ARDS patients. Whereas in cardiogenic pulmonary, you will have uniform B lines all over the place. Sometimes you may have some pleural effusions, especially on the right side as compared to the left one. Now coming to the other aspect of the ARDS, when do you decide to prone the ARDS patient? Now, when you have a patient, ARDS patient on NIV, or maybe he's intubated, or you want to decide whether to prone or not. So how do you decide that? You just scan the anteriorly, use your a linear probe or a convex probe, look at the A lines and B lines, what picture you get. If you are getting B lines anteriorly, it is the time you probably may add an invasively ventilate or decide to prone the patient. But if you have A lines anteriorly, then I think you shouldn't be proning this patient. At the same time, you need to scan posteriorly as well. Look for the C profile. If you have dense cantilever consolidation posteriorly and anteriorly, you have only A lines. If you prone these patients, they might benefit. But if you have A lines means only air in the alveoli. Posteriorly, they have a C lines, a C profile. You have a lot of consolidated lung. If you ventilate them supine, you probably will be just distending their anterior lungs. Those patients usually need to be, they may benefit from proning, particularly A lines anteriorly, C profile posteriorly. So that is how you decide about a proning aspect. The third thing is about how do you titrate your PEEP. Now it depends on what are the findings you are getting. We discussed A means air in the lung, normal alveoli, aerated alveoli. Okay. Fluid in the lung, which is a B lines, diffuse B lines. Now, when you are trying to titrate the PEEP, you need to have a probe in a place and see how much change is seen in the aeration and deaeration. So suppose on the lateral aspect, you put in a probe and you are gradually increasing your PEEP. Initially, you have a coalescing B lines or diffuse B lines. Suppose if you increase the PEEP up to a certain extent and you see there is some change in B lines, they were coalesced, but they are reduced in frequency in the numbers, say from 7 to 3. So that is the thing I probably see that now air is being going into this alveoli. You might decide to see how it helps in terms of oxygenation at this place. Okay, so there is a score for it. If you have A lines, which is given a score of 1, if you have diffuse B lines, which is given a score of around 3. So from 1 to 3, that is for aeration I'm talking about, and 3 to 5. A consolidated lung will have a 5 point given, 5 score. A B lines will have a 3 score. And the air in the alveoli will have 1 score. So in a ARDS, severe ARDS, you have a 5 score, or suppose in the 3 score in one aspect, one region. I'm just talking about one region. So you need to have, there are 6 regions on each sides. Okay. So you need to count those regions and have a score together. So you put in a probe on one side and seeing that the score is around 5. And now you increase the PEEP from 5 to 7, 7 to 10, and a score. Now the C profile or tissue-like profile is changed to your B profile. Then it's come from 5 to 3. So there's some change in score. That's a aeration score. Okay. So if it is changed from 5 to 1, that there is the C to A line, then it's a change of 5. So that's again aeration score. This is how the score is calculated, but it's a dynamic thing. You'll have to keep on doing when you're titrating the PEEP, you have to keep on doing the ultrasound and keep on scanning the ultrasound and titrate the PEEP accordingly. That's how you do the titrate the PEEP or ventilation when we are ventilating the ARDS patients. There's one more thing I think somebody has asked about. Anything else, Dr. Gunada?
No, sir. And what about the use of ultrasound in the prone position, sir? How do you actually do the ultrasound?
That's what I told you. Once you have prone the patient, you need to scan first, baseline scanning. Particularly backside only you're scanning, isn't it? So on the backside, you have scapula in the place. So it's below the scapula and interscapular regions, and on the sides. Anteriorly, we are not interested in anterior scanning because we are proning when you have a dense consolidation in the posterior aspect. That time we are proning, isn't it? Those patients. And anteriorly there is A lines. Those patients are usually prone so that we can try to aerate the posterior aspect of the lung and get the air inside the lung. So you need to keep on scanning, maybe hourly, maybe 2 hourly. It all depends how is the patient responding to your ventilation.
Yeah.
There is no fixed protocol as such. Hourly or 2 hourly or 3 hourly.
I think there is one question on COVID pneumonia. Any
Yeah.
specific feature on the lung ultrasound?
Yeah. So
yeah.
you want to get Kodar? Go ahead.
Yeah, so what we saw in COVID pneumonia is that the first and foremost was break in the pleura. The pleura was irregular, the pleura was thickened, okay, and obviously you had subpulmonic consolidations, which you saw. So I showed you on one of the videos there. I can show you again if you want. So this is how it goes, and you have B lines, which are again non-homogeneous. It may not be as homogeneous as what you say in cardiogenic pulmonary edema, and obviously the heart was normal. So if there was no COVID complication in the heart was normal. So you saw, and pleural effusions were very, very uncommon in COVID. So if you see pleural effusions, we think of some other cause. Maybe it might be a cardiogenic problem which we see with COVID, or it is something else apart from COVID. So pleural effusion had a good negative predictive value for in COVID. And the hallmark was this break in the pleura with subpulmonic consolidations and B lines, which were non-homogeneous, of course. And posterior-basal aspects were predominantly involved. So if you see the Plaps point, the lower prone and the upper prone points were more involved. One more thing I would like to add to what Jayan said is that in COVID, we used to use awake proning. So in awake proning also, we used to see that if the patient had a significant A lines anteriorly, which Jayan said on blue point 1 or quadrant 1, quadrant 2, zone 1, zone 2, zone 3, we used to prone them with awake proning and see the difference in the aeration deaeration here in prone position as well as supine position. So, and that used to really help. So obviously, if the patient had A lines anteriorly, the patient was not much involved, meaning the lung was not much involved. But posterior basal B lines along with anterior involvement, that means the lung was floridly involved. So of course, aeration deaeration score is used, but you require, as Jayan said, you require a close follow-up. You have to repeat the ultrasound after 2 hours or after whatever you increase the PEEP. After the increasing PEEP, you have to again repeat the ultrasound and see how it works.
Yeah.
One more thing about COVID is the characteristics, particularly in early COVID, actually. I'll just share the screen if it is okay with you. Shall I share
please.
one? Okay. So this is what you get in early COVID, particularly when you have ground glassing scene and small subpleural the consolidations. So can you see that? Screen is seen?
Yeah.
Yes.
Yeah. Okay. So you have beam life effect. You have this is what the Kedar taught you. When you have a B lines, A lines usually disappear. When you COVID, you may get a mix of both. Sometimes you may see intermittently A lines and B lines are coming like a flashlight. When it is moving, they are coming like a beam like flashlight. This picture is normally seen in early COVID, usually in for 7 to 10 days. When you have ground glassing seen, this is what is seen normally.
Flashlight blue points are analogy for the ground glassing on the CT scan.
Yeah.
Okay. And my another question to Dr. Aditi. So if a patient of pulmonary embolism, so how do you approach if you have an ultrasound, and how it will help you to decide the course of the management? Just in a nutshell.
Yes, pulmonary embolism, usually, unless there are subpleural infarcts, you may not see a lot of changes in the lung ultrasound. So, in fact, when the blue protocol or the extended blue protocol says that if your lung ultrasound is normal and your patient is hypoxic or your patient is hemodynamically unstable, we have to do an extended blue protocol or an E-blue protocol where we look at the right side of the heart to see if there is right atrial, right ventricular enlargement, and extended to the venous ultrasound of the lower limbs to see if there is any clots in the lower limbs. This is one of the cases where they say that conventional imaging is more important, and you have to have a high index of suspicion, or pretest probability should be high. It's always in conjugation with clinical diagnosis. And rarely, if there's an extensive infarct from the pulmonary embolism, we may be able to see subpleural consolidation. I just wanted to also add regarding the PEEP titration. I don't know if a lot of people have heard of the concept of dynamic recruitment. So what happens in a lot of patients, we see that with breathing, especially in the PLAPS point, with breathing, as soon as you see B lines during expiration, but when they inspire, or the other way around on a ventilator, basically when the lung expands, the B lines become less. And when the lung goes back into normal state, the B lines appear. This means that the patient would do better, or is automatically recruiting with the tidal volume. And in these patients, if you increase the PEEP, usually they benefit from a higher PEEP.
And do you scan for the lower limb veins also in patients with pulmonary embolism?
Yes, we do. Yes, definitely. The Blue Protocol does involve scanning the veins.
Like femoral and popliteal?
Yes.
Okay, thank you.
Can we use the false protocol along with the blue protocol? How do we differentiate the findings with these two protocols? And another question is, how do we use ultrasound in an irradiated lung? Would the findings be different, like presence of B lines or A lines in an irradiated lung, especially those patients who have probably a CA breast, underwent irradiation, or CA lung patient has received radiation therapy? Would the findings of A line, B line would differ in these patients, or would it be the same? My question to all the panelists, including Dr. Kedar.
Dr. Rishi. So Dr.
Dr.
Rishi,
Rishi, you're around?
So your first question, I think I'll just
Yeah.
take for a first question. It was regarding the
difference between the blue
ERDS
protocol and the
your,
false protocol.
blue protocol and your false protocol. See,
Yes.
whenever we are scanning, particularly as Dr. Kedar has already said, we are scanning multiple organs. Single organ will not give us any information about anything.
Yes.
So it has to be, particularly when you are doing the blue protocol, the heart comes in that. In blue protocol, we are trying to rule out one by one thing. The heart has to come at some place when you need to do an echo as well at some point. You need to scan those things. We are talking about false protocol. False protocol comes in picture once you have ruled out other shocks. First, you will be ruling out a cardiogenic shock. So you need to scan that. Second thing, you'll be ruling out hypovolemic shock. Third thing, you'll be ruling out first is the life-threatening is going to be the distributed pneumothorax. You'll be ruling out first. Then comes the obstructive type. That is your tamponade cardiogenic shock. You'll be ruling out. Once this ruled out, then you come to the false protocol. You're scanning the lungs and trying to give the fluids. Scanning the lungs for the B lines. False protocol, when you're ruled out the first two things like the pneumothorax and the cardiac tamponade, third thing is remaining is the ruling out the fluid, isn't it? Whether the patient has deficit in fluid. Okay. So what will be the picture in ultrasound in this case? Is a clear air in the lungs, normal dry lungs. You will have A lines, lung sliding present. At this point, you will be thinking now, okay, my patient hasn't got a cardiogenic shock. My patient hasn't got a pneumothorax.
Septic shock.
So my septic shock will come later. My patient hasn't got this thing. Lungs are clear. So then I need to give some fluids because the patient is still hypotensive. So then you give the fluids and keep on scanning the lungs. That's where I think somebody has to be all the time with the probe around. Your pulse point is give one where you start getting, you're giving fluids and looking at a response. If you get a response in terms of blood pressure improvement, you'll be stopping the fluid boluses, isn't it? Suppose if you are giving fluids, but there's not much response is seen, at some point the B lines start appearing down in the bases. That is the point you decide to stop now. Now, okay, my patient is now adequately filled up. The fluid is coming inside the lungs. The patient is still hypotensive. That is where you would the distributed shock or septic shock will come in picture. You will be adding vasopressors at this point. So it's a combination of both. You have to do a lung along with the cardiac. Both has to be done. One complements each other. That's was first question. I think second was irradiated lung, isn't it?
Yes, yes. So
irradiated lung, you need to know whenever you are doing ultrasound of the lung, you need to do a clinical picture, a disease. Emphysema, suppose chronic lung diseases, patient has got fibrosis, fibrosed lung, pleurodosis, emphysematous lung. Irradiated lung, we have a lot of fibrosis, a lot of interstitial fibrosis. So in those patients, you will have a mixed picture actually. You will have a lot of multiple B lines. You may not get a sliding as well. It will be irregular pleural line. So you may not see sliding because lung is adherent to the pleura in those irradiated lungs. So it's a mixed picture. You will not a clear-cut B lines seen like multiple B lines moving with the respiration. That you may not get that picture in this case. In irradiated or fibrosed, or where the lungs are stuck to the pleura.
So how do we assess then whether patient is in fluid overload or
So
there
again,
is
it's a combination of
pneumothorax?
both. You need to.
I know the clinical tools will be very important here, and
Yes,
then other
yes,
parameters
yes.
are
So
very important. But ultrasound wise, I mean, how would we be able to really pinpoint whether this patient
if you are right
having
from
some
the
bleeding?
admission, if right from the admission, if you are doing the ultrasound, you know the irradiated patient, you will have a baseline picture in your mind.
Yes.
What's my patient's lungs look like?
Yes.
Where once the patient comes in ICU, then you start giving therapy, then you will have few new signs adding in or something. Then you will know, no, this wasn't there before. Now something is coming up here. So I probably give more fluids. Talking of fluids, I'm talking particularly we are talking when it comes to that, we are talking about fluids, isn't it? Am I giving more fluids? Am I giving adequate? Am I low on the fluids? So you already have a baseline picture of your lung, and then you start giving some fluids and you're not responding, and you're scanning it again. Earlier there were few B lines, now they are increased. You probably will decide, isn't it? Now, okay, now this is time for me to stop. At the same time, you'll have some idea about his heart condition. What's his heart function? Is it a low, a moderate, or severe? So that also will have picture with you, isn't it? You will be scanning his IBC as well, looking at that thing. So it's a combination of all, which you can decide about therapy. So baseline lung picture is very important. Ultrasound picture.
And the
Any
trends,
patient.
probably
Yeah.
it has to be followed up with the trend. What is the
Particularly
baseline?
particularly our junior students, when they get confused, when they get a patient in ICU, they start saying B line right from the admission. And they're worried. Oh, patients, patient has B lines. How can I give fluids? But here the history is important. If patient is having fever history, 2-3 days cough history, and he has got B lines, he will have B lines if he has got pneumonia, isn't it? They may not be having C profile because it's early pneumonia. So you will have diffuse B lines, some posteriorly on one side or both side bases. So the clinical history along with the ultrasound picture, which is very important. In those patients, if you have to give fluid if the patient is hypotensive, isn't it? There they get confused. Oh, B lines, how can I give fluids? But some patients do require fluid. Those patients will require fluid if they are having infection, isn't it? So it's a combination. One thing complements each other.
Well, absolutely. Thank you. Thank you for this update. We
So,
have a few more questions.
yeah. So one of the questions was asked, like, the role of the ultrasound during the weaning from the ventilator. So what are the parameters usually measured?
Itself is a big topic actually. Weaning from the ventilator. There are 2-3 things you need to. A lot of calculations are required if you want to go into details.
Just in a nutshell.
One thing is, you need to have a scoring how the patient is aerating. I don't remember exactly. It's around below 20 or something. Aeration score. How it is aeration is patient is aerating. You will be looking at the. Let's take the one complicated. Let's take a normal patient who is just you're trying to wean off. He had a pneumonia. You're trying to get him off the ventilator. He's on a CPAP pressure support mode. Now you want to take him on a TPs and see. On CPAP you had a proper A profile on all the lungs, and you put him on a spontaneous breathing trial for some time, and you will start seeing some B lines somewhere down. Earlier which were not there. Now they are appearing, isn't it? So there is score involved in that. I'm just trying to keep it simple a little bit. If there are B lines, I think this patient is still probably not enough adequately taking tidal breaths. That's why he's collapsing. You're trying to get the B lines at the basis. So this patient probably once you extubate, he might not do well. Might not. The other thing is now, that's one aspect. The other aspect is why he's not getting breathing adequately, then you have to look for the diaphragmatic function. There are a lot of things are there, other things. I think as Kedar said, diaphragmatic function, again, it's still a big 1 hour discussion on that. So keep it simple. When you're trying to get the patient on a spontaneous breathing trial, look at the lungs, put him on a TPs and look at his lungs again. if there is any change is going to be definitely increasing lines, worsening things, isn't it? B lines. And provided his hemodynamics is normal, they is not adequately fluid overloaded earlier, and after putting on a spontaneous breathing trial, he's showing some signs. I think you need to wait here. Hang on. Let him get more comfortable with his breathing. Let him have more good tidal volume. That's how I think, to keep it simple, it can be done at the bedside.
Oh, yes.
Thank you, sir. Sir, Kedar sir, what book and what resources you recommend, sir? One of the junior actually, they have asked for the ultrasound, to learn the ultrasound.
Bible of
And what are the
again, like
focused
instant,
programs? Yeah.
but
Yeah,
also
absolutely.
a lot of other resources also. So if you see, there are a lot of other resources, like our WinFocus also has a lot of teaching resources. You can avail of those resources also. And these books are available as PDF also, so you need not buy one. You can keep it in your mobile also. So by far, if you want anything about lung ultrasound, Dr. Lichtenstein's book, The God of Lung Ultrasound and Whole Body Ultrasound, his whole book is worth reading. And that's reading like Guyton. He talks to you as you go ahead. So I would recommend everyone to get hold of the book, whether it is a PDF version or the paper version. I personally am an old school of thought person, so I personally like the feel of the book. So I have a couple of copies of the books. But you have a lot of resources now. You click on the YouTube and you get a lot of resources now.
Yeah.
Of course, there are consensus guidelines also of lung ultrasound. There are many papers in lung ultrasound, so all those can be used. But
so I think this
basic
thing is
book
said.
has to be adhered to.
Yeah.
Basic book is Dr. Lichtenstein.
So, Dr. Aditi, you want to share something on the screen for this?
Sorry, I just have, we written when I was in Toronto, we written a chapter with Dr. Alberto Goffi on the approach to ultrasound, lung ultrasound in critical care. I'll probably send it to you and you can send it to everybody if you like. It is printed in the ISTCM USA second volume. If it's a concise of what was discussed today, and like a book is definitely much better, but for those who don't have time to read the whole book, this is just like a 4-page description of everything. I'll send it to you and you could probably WhatsApp it to everybody.
Sure, definitely. That will be a great help.
Thank you.
So I think with no more questions, sir, any message you would like to give, sir, to our new trainees and to our new joining for the ultrasound? Kedar sir or Jen sir?
Practice. So go back, use your probe regularly, and don't forget your basics. So ultrasound is not a substitute for history taking and clinical examination. It is a tool, which is an aided tool to get to a diagnosis. But it's one of the great tools, and it has great utility in any place, whether it is emergency department or the ICU or the OT or even the ward, to get hold of things and change the protocol as per the need of the patient and improve the outcomes. So everybody should practice it, not just didactic lectures. Didactic lectures are the basics, but you need to go back and implement those at the bedside.
Yeah. Sir, just one question, sir. Basically, next week we have a program on the ECMO by Dr. Thomas Muller. So I request everybody to join. But by this time, what's any role of ultrasound in this kind of ECMO patients when the patient is on ECMO? I know this is one of the topic which is not usually practiced in many of the centers, but out of the curiosity.
Yes, a couple of places. Role of ultrasound ECMO is putting a lines first. And second thing is, when you're trying to wean off, you'll be looking at lungs, how they are doing earlier, because you gone on the ECMO because the bad lungs, isn't it? How they are doing in terms of aeration. So here, when you're trying to wean off, I think the role comes in picture. I'm not an ECMO expert, but that is where the ECMO will come into the ultrasound lung will come into picture in ECMO patients. When their aeration is, you will be monitoring their aerations, how their lungs are doing. Earlier, they had a bad C profile or in homogeneous picture on how they are doing now. So once you start seeing the reducing B lines, reducing C lines, more increasing A lines, then you will probably, it is time for patients to come off ECMO.
Can I add to that?
Short. Yeah, please.
So then also, if you, for troubleshooting during ECMO, if your patient starts desaturating and you were not sure if your lines have been, the position has moved, you can do the echo and see for the jet, especially in a double lumen Avalon cannula, etc., whether the jet is directed towards the tricuspid or it has moved, whether they're too close by and there's recirculation, etc. All those things also can be picked up by an ultrasound transthoracic. And TEE definitely will help us with more information, especially also both echo will help if your RV is getting overloaded once you're taking the patient off VV ECMO, or if your LV is ballooning or not with your flows on VA ECMO. These are, and whether it needs a shunt, etc., are important things while the patient is on ECMO that we need to observe for every day.
So basically, it is the monitoring of the aeration index with the help of ultrasound, which will help us to guide whether the patient is improving with the ECMO or not. If there is improvement in the aeration index, probably the ECMO is working, and then we can wean patients depending upon the aeration index. If the aeration index has improved, probably we can go ahead with the weaning. But at the same time, we have to look at the other things also, like these patients do develop critical illness, myopathies. Diaphragmatic weakness is also very, very common. So these factors also need to be taken into consideration while we are weaning the patient from ECMO and using ultrasound together. It has to be an additional tool. It cannot be a substitute to the routinely available tools. That is what we need to understand. And hand holding is very, very important. We need to learn the machine. We need to love the machine. Okay, unless we love it, we won't be able to use it. So we need to have that approach. Handling with the machine day in, day out is the way to learn ultrasound properly. Definitely, theoretical aspect is also very, very important, but hand holding is the most important aspect.
Couple of more, I think, questions are remaining. Somebody has asked about Blue protocol. So which itself is a big topic. Blue stands for only bedside lung ultrasound emergency. Basically, you are trying to rule out one by one pathology. I would just keep it in short. You're ruling out the pneumonia, you're ruling out the exacerbation of COPD, you're ruling out the asthma, you're ruling out the cardiac tamponade. You're one by one, you're ruling out in the Blue protocol. The second is asked, a left upper and lower quadrant blue point is not difficult to visualize since there is a spare, the precordium. Yeah, so that there is the blue pointer design is such a way that you are trying to move around the heart there. So there, if you do it on a patient, you will be leaving the heart and you will be just scanning the lung in the blue points.
Okay, thank you, sir. So if there are no further questions, I think we'd like to wind up the sessions, but it's a wonderful session, and I thanks Kedar sir for the wonderful presentation. I think that this is definitely be an eye-opener for all our DNB trainees, fellowship students, the IDCCM students, and it will definitely boost them in the practicing the ultrasonography. I also like to thank Dr. Jain sir for the elaborative discussion, Dr. Aditi and Dr. Rishi Kumar and Dr. Achilles. So if there is no further questions, we can wind up. So thanks all for attending today's session. And next,
thank you very much, sir. Thank you very much, Jain sir. Thank you very much, Kedar.
Thank you very much. Bye-bye.
And next week we have a session on ECMO by Dr. Thomas Muller. So I request everybody to please participate. We'll sending the link.
Yeah.
Thank you.
Thank you.
Thanks.
Yeah. Thank you, sir.
Thank you.
Bye-bye.